So she should be essentially making like how much urine?
2.6.
32.6. So she's kind of low, but not that ridiculously low. But what else do you guys notice with this patient? What is something that you're like, why are we doing this if we're pulling it off? Yes. So do we all see that we are giving her fluids? And that's sometimes human error, or just, you know, sometimes the physicians just click all the way through. They're like, they're releasing sign health orders from like a post-procedure. So that's always something that we have to remember. Have that healthy skepticism to be like, is this normal? Do we really want to give 50 mils an hour added to our patient? No, we do not, because we're pulling it off anyway. That's an extra fluid to pill. So, great job. We identified that that fluid order probably needs to go away, and her urine output is, you know, slightly diminished, and she is flat abdomen, but also generalized edema. Okay, so her drug toxicity screen shows positive for acetaminophen. What kind of injury failure is this? Pre-renal, intrarenal, or post-renal?
Say intra.
Intra. Because most of the drugs that like patients will take is intra. So like the metformin that we see with our patients, the fentanyl that we love with our meth head patients, they'll usually have intrarenal. And we already know that when someone's in hypovolemic shock or trauma or cardiac shock, that's most likely pre-renal because they're not getting enough fluid, right?
Why would I honestly think that's
No, you're
I
fine.
know. I was just funny though because I felt really bad.
No, you're good. You're good. This is actually based on a real patient. I was like, why are we doing this? Okay, so we have orders for CBHDF. Our patient fluid removal order is 50 to 200 mils an hour. Blood flow rate is 200 mils an hour. Our pre-blood is 1,000 mils an hour. So our wash is 4K 2.5. Dialysate is 1,000 mils an hour, 4K 2.5. And post replacement is 800 mils an hour, 4K 2.5. Yeah, seems like simple orders. Okay, so essentially when you think about CRT and simple calculations, essentially what you are doing is you're taking the intake of all the fluids minus their output plus the patient fluid removal order. So for example, if I'm adding up all my infusions and that they're at 100, and then my urine output is 10, so that's really what number is that already? 90. Because we're doing 100, which is A, minus 10, B, the output of my urine output, and then equals 90. But let's say we want to pull fluid. How do we determine what number or what vital sign will help us determine how much fluid to pull? So I hear blood pressure and MAP. Nice. That's what will help us determine. Do you think I want to go 200 right away? Girl, no, because I'll grab the crash cart and call my friends. What I can do, even though you have like 50, you can technically go 0. 50 I would say is like, ooh, why? I would literally just start low and slow. And it's okay because it's your nursing judgment. Because what if they don't tolerate that 50 pull per hour? What if you need that time to equilibrize, I just created a word, to like wait and see, right? Okay. So let's do the calculations together. Let's say we have 50 mils of saline, our propofol is 13.3, fentanyl is at 5 mils per hour, norepinephrine is actually going at 7.5 mils an hour. We have osmolite, the TPN at 45, and urine output is 25. So what would our patient fluid removal rate be into the CRT machine?
So we're calculating the normal saline, propofol, fentanyl, norepinephrine, and osmolite, right?
Are we calculating the normal saline? Are we calculating the normal saline?
Well, yeah, you have to.
We're not, remember, we took it away.
Oh.
I got you. Sorry, just wanted to get you guys. Okay, so technically we're gonna go ahead and do, yeah. So what number?
I don't know.
I'll
Yeah.
calculate 2. So then we'll do
70.8.
That's what I got,
and then
70.8.
let's say we're doing the order,
7.8 minus 25.
and then let's say we're pulling 50 first, because they can color.
Are we doing 50 instead of 0?
What's that?
You say we're at 0?
We're gonna pull 50. So what will we be putting into the machine?
Oh, plus, so that minus that plus, you want 50? So we do 95.8.
That's what I got.
So 95.8. But because this doesn't go by decimal, you can try. It's up to you how stable your patient is. If they're stable, I would go up to 100. If they're not, if you're like, you want to rock the boat, you can technically go 90. So it's literally up to your discretion, right? Because like we have to think with our whatever we're doing, we want to empower ourselves with the knowledge and like to be careful, because we don't want to rock the boat, right? I mean, that's not going to rock the boat by 10 points if we start either at 90 or 100, right? But it's up to your discretion. But that was correct. Okay. Anyways, okay, let's say 30 minutes after putting the patient fluid removal into the CRT machine, the monitor starts alarming and below are the vitals. So we are at normal sinus at 98. Our blood pressure is 80/60. Let's say our MAP is really crappy. Respiratory is 22. And let's say she suddenly is not on her nasal cannula. She's still ventilating. Sorry, you guys. So what are your priority interventions? What would you do? What is your assessment and outcomes?
Reduce the pull.
So how low would you reduce your pull?
What were the,
You're at 50, or let's say technically,
well,
0.
technically we're pulling 100,
right?
right?
Technically,
So you
yes.
can go to 50,
Or
and see
you-
if it, or 0.
Yeah, exactly. So you can go to 50 or 0, and it's okay if you go to 0. Now, what else would we do? Our patient's MAC is still crap.
If you reach
Go up
like
on the,
95.
yep. And then we can try to lay the patient supine just to equalize the fluids. Now, what else are we gonna do? What's happening?
Call you.
Girl. Okay, so we can technically let our ICU docs know that what's happening and let them be informed. And so now we want to understand, was the fluid shift way too hard? Now, what do you think moving from here, what should we do next?
A lesser amount of pull if we're gonna try,
Okay,
or just not.
okay. So what,
This was the silver puppy lady, right?
yes, what would you want to pull?
Is it still overloaded?
Just what you're pulling out, like not anything, oh, what you're putting in, right? 'Cause
So a
we
lot,
added something 45.
Yeah. So a lot of the times the physician can be like, hey, let's go ahead and start pulling whenever you're stable. Let's try to get that levo back to where it was baseline and then start pulling. Because the thing is, we don't want to keep pulling and increasing our levo, right? We want everything to equalize and also pull off. So what you can do is like go up increments from cut it in half, that 50, go to 25. So if you know that's not a really good pull, you can just cut it in half. So you can go 0, and if you feel brave, or not brave, try 0 the next hour, and then let's say the next hour try 25, and see how that is. And that's all up to your discretion to do 25 until you're finally pulled. Because yes, some people will just be aggressive, like I'm just gonna pull fast. But then again, we have to remember how many pressors is this patient on. And you'll hear a lot of experienced ICU nurses say like, girl, you're on 3 pressors, are we even gonna pull anything? Yes, we can if we do the right interventions, but it also takes trends over time and how we'll see this patient.
You're also like, you're also feeling.
Yes, especially if there's sepsis and like whatever cytokines, whatever gunk gets in the filter. Okay, let's say 4 hours later, you have been increasing the patient fluid removal to 100. Yay! So the patient's tolerating that well. Your MAP has been above 70. The intensivist instructs you to wean off the norepinephrine drip. You still notice that she has generalized edema 2+. You note this to the intensivist and he orders 40 milligrams of Lasix 1 time. Discussion. What is happening? What is your next intervention?
Question to order.
So is this Lasix appropriate for our patient?
No.
Absolutely not.
Contact
Yes. Well, hopefully the nephrologist will, and also will understand, but we know that Lasix already harms our creatinine, right? It'll probably like increase it within the next 12 hours because our kidneys are pretty slow with reacting, right? What other things do you think we'll do? Or what do you notice here with the patient?
Third spacing.
That third spacing, right? And then what do you think we'll do? Correct. So don't be surprised that you'll see these type of patients, and it definitely takes to us to feel against the balmy prominence of either the shins or even their forearms to be like, oh crap, they're still like the Michelin man, let's go ahead and get some albumin. And what you can suggest is, right, we're not like physicians, and like, but we do run the show. We don't want to be like, you need to order this now. You can suggest, be like, hey, Dr. Garcia, can we do Q6 albumins? And most likely that will probably help the patient because you'll just see either one, an increase of your blood pressure, two, increase of your output, and now we can pull more fluid, right? So you'll now see the balance between like, okay, now I can pull a little bit more and then go down on Levo too. Okay, any questions? And then how do we know, with let's say this patient's on CRRT for 3 days, what indicator will tell us that this patient's doing well?
Well, it depends on what they're on it for, technically.
So I know it's a loaded question, but one of the things that we can sense or tell the patient's doing well is seeing their trend of their daily weights, if it's going down. Yeah? Okay. Okay, let's say you notice that the urine output's dropping off from 30 mils an hour at 10 o'clock, or yeah, 10 o'clock, 20 mils an hour at 11 o'clock, and then 5 mils an hour finally. What do you think is happening?
Are they on CRRT stuff?
Yes. Don't think too hard.
CRRT is doing, hold on, the food they're not doing.
They can recover and make some urine. You notice your patient's grimacing, and then you do an abdomen assessment.
You notice the stomach bladder, so it could be an obstruction or retention.
So what you can do with this is make sure you attach a 10 ml syringe. I like to use 10 ml syringe. People are like, use it 3, it adds more pressure. Like, no, girl, I'll use a 10 ml syringe, clean the top with saline, and then flush it, because maybe it could be sediments. And then what are you gonna wear when you flush it?
I should.
Yes, because that's what happened to me. Like, it sprayed everywhere, and it went in my mouth. So,
You're talking about the Foley, right?
yes,
Oh.
like it literally popped off, and 1 liter came out in my mouth, and I was screaming, and I was like, oh God! And then Agatha goes, oh my God, did you get a bath? I'm like, girl, go get me new stuff. And thank God I have short hair with this, so, yeah. So when in doubt, just do, again, like these, yes, this is a lovely machine, but our basic nursing care still counts, right? Like always investigate before we're like, oh, it's probably not working, let's change it out, right? So, I mean, I wanted to change it out, but Agatha's like, oh, just flush it. I'm like, okay, girl. And she's like, oh, I won't be there. I'm just gonna walk over here. Like, oh my God. So, okay. Any questions? Okay. We're all done.